Welcome to week 6 for hematology. This week we are going to finally get started with the first of our anemias. So 2 PowerPoint lectures to go through today. I will share my screen so we can get started. Give me just a moment. All right. So the first of our 2 PowerPoints is going to be chapter 19. It used to be chapter 18, the old edition, new edition, chapter 19. So 19 is just kind of a nice overview of anemias. It's an introduction to them. So we will start with this one first. All right, so the word anemia itself literally means without blood and is without emia, blood. So the word itself tells you it's without blood, or in other words, reduced number of red cells. As a result, reduced oxygen delivery. So there's less oxygen getting to your tissues. Most often, and actually not most often, but anemias are always due to something. You are missing or lacking something in your body. There's something happening in which you're not getting enough of something, or there's another disease getting in the way. Something is going on that results in you getting into that anemia. And that's where we come in, and we're going to start learning the different types of anemias and what causes them and the symptoms and signs and all that stuff and what separates them all out. As far as clinical findings, anytime we talk clinical findings, we are discussing symptoms of the patient. When the patient goes in to see the doctor, what do they complain of? What do they show signs of? That kind of thing. Clinical findings or symptoms. So with anemia, typically they're going to do a whole history, physical exam. If there's signs of jaundice, which is the yellow coloring to the skin and eyes, that's usually an indicator of hemolytic anemia. Otherwise, most anemias are going to just show pallor, where they're really pale in color. Other findings that are really often included with this is fatigue and shortness of breath. SOB stands for shortness of breath, not what you think it might stand for. So those are very common. When you're short of oxygen, you're going to get tired, you're short of breath. It makes sense. If you don't have that much oxygen getting to tissues, those signs are going to kind of correlate with that. And then there's some anemias in which you start to crave things, and that's called pica. So you might crave substances like ice, clay, cornstarch. Iron deficiency anemia, pica often goes with that one. I know when I was pregnant, I was really iron deficient, and I craved chewing ice. Oh my gosh, I chewed ice my whole pregnancy. So that's just really common to find. All right, moderate anemias are going to be considered anything where your hemoglobin is between 7 to 10. Remember, for women, a normal hemoglobin is 12 to 16. For men, it's typically 14 to 18. So, whoops, I did not mean to go there. Okay. So, at any rate, a moderate anemia is going to be considered anything 7 to 10. The doctor doesn't even like you sitting at 10. It's hard on your body. They want you up in normal range, but you might not see a ton of signs. You're probably going to feel sluggish, slowed down at a moderate anemia. At a severe anemia, that's where it really puts the hardship on your body. So this is anytime that hemoglobin for sure drops to less than 7. I would say that'd be even less than 8. Typically, they're already looking at, should we transfuse you with blood? So in that case, you're going to see tachycardia, which is an increased heart rate. So your heart's extra pumping, just trying to get blood out there somewhere, oxygen to your tissues. So your heart's trying to really overcompensate, and so that's where it gets that increased heart rate. And you also will see hypotension, which is a low, kind of a drop in your blood pressure. If you don't have very much blood, not a lot of blood pressure there happening. All right, so the thing with your body will be is that it will adapt. As you get anemia, if your anemia builds over time and develops over time slowly, your body adapts to it then as it comes on. So what happens to adapt is your body will deliver blood a little bit more rapidly to make sure you get any oxygen out there. Again, it will try to pick up the heart rate, the respiratory rate, the cardiac output. We'll also pick up that 2,3-bisphosphoglycerate. Remember, that's 2,3-BPG. That's that whole thing that helps oxygen get delivered to the tissues. It helps that oxygen get released off the hemoglobin and delivered to the tissues. So all of these are things that your body can do to adapt over time to that anemia developing. As far as the lab goes, CBC, that stands for complete blood count again. That's just going to give you a nice big overview of the patient's blood. They will tell us how their white cells are, the red cells, the platelets, different indices, things like that. So it gives us a nice big picture view of what's happening with that patient's blood. We could do a reticulocyte count, so that's where you're actually looking at the percentage of reticulocytes in that person's bloodstream. Again, all of us have some reticulocytes in our blood. Around 0.5 to 1.5% is reticulocyte count normal. Anything higher than that 1.5% or 2% reticulocytes in your blood indicates that your bone marrow is increasing the red cell production and putting more red cells out. So if you were to have a high retic count percentage, it tells us your bone marrow is really trying to pick up and produce red cells and compensate for the anemias. We especially see this with a hemolytic anemia situation. Hemolytic anemias are those ones where your red cells are being destroyed due to some process, and so we really see the bone marrow kick out more red cells to replace those destroyed cells. So usually a high retic count will go more with the hemolytic part. We'll also want to do a microscopic exam of the blood smear because we want to look at the red cells. Under the microscope is the only time that we can see if there's a change in shape to those red cells, what we would term a poikilocyte. Your analyzer will never tell us if there was an actual shape change to the red cells. Only we can see that under the microscope. We're also going to kind of verify what is the size of those red cells. Do they look really hypochromic or normochromic? You know, do they have any occlusions? So we're just looking at the overall morphology of the cells. And then worst case scenario, you would go to a bone marrow. We're not going to just jump to a bone marrow. That is not something we jump to. For anemias, there's easier ways to figure out what type of anemia is happening before a bone marrow. Bone marrows are very invasive and painful, so this is kind of a last step process. If you were to jump to the bone marrow, it would help kind of determine the maturation patterns, how they're maturing, what they look like, that kind of thing of the cells. Other lab tests that you could take into account is urinalysis. You could look at the urine, see if they have blood in their urine. Maybe they're losing blood there. You could do an occult blood test. That is looking for hidden blood in the stool. So maybe they have a GI bleed and they're losing blood out in their stool, and that's what's causing their anemia. Could be they have a parasite. And then most commonly is iron deficiency anemia, where they're just low in iron. And remember, all those red cells have iron in every hemoglobin in there. So if they're low in iron, that would explain why they're low in blood in general and being able to deliver oxygen. So there's those iron studies that we've already mentioned in our iron chapter before. But again, that's a quick, easy draw of the patient's blood to run those iron studies on the chemistry analyzer. All right, so now that we've kind of done a broad overview, there's two basic mechanisms of anemia. We have ineffective erythropoiesis, and on the next slide, we'll see insufficient erythropoiesis. So we're going to start with the ineffective here. So we have anemias that fit under this, in which basically the production of their cells are defective and are trying to be destroyed before they even leave the bone marrow. So the red cells that they're trying to produce aren't even good quality. So examples of this type of anemia would be megaloblastic anemia, thalassemia, and sideroblastic anemia. These are all three that fall under the ineffective erythropoiesis, in which they have defective progenitor cells, and we're trying to get rid of them before we even let them out. In insufficient erythropoiesis, it's just like it sounds. It's not enough quantity. So there's not enough, it's not sufficient. It's a quantitative lack of red cell precursors in the bone marrow, which leads to a lack of red cells, period. So this would be commonly seen with like iron deficiency anemia, aplastic anemia, which is like a bone marrow failure thing. So those are examples there. And we're going to learn all these anemias. So don't worry if you don't quite understand each one. All right, as far as evaluating anemias and trying to separate between them and see what's going on, and we can do that retic count. That's going to help determine if it's a production defect or early destruction. Retic count will go high in early destruction with hemolytic processes. And then the key is going to be our red cell indices, our MCV, MCH, and MCHC. We categorize our anemias according to those red blood cell indices. So the first category would be is if everything's normal within reference range, what we term normocytic, normochromic. So the red cells are normal in size, normal in hemoglobin concentration. So this would be aplastic anemia, kidney disease, because yes, that does cause anemia. It could be sickle cell anemia would fit in here as well, in hemolytic anemia. So aplastic anemia, kidney disease, sickle cell anemia, and hemolytic anemia all would have normal size, normal look to their red cells. So that's what they would look like, nice, healthy red cells, a little bit of a central pallor in the center, but not a ton of central pallor, just like a little bit. Everything looks pretty even for size when you look at that whole entire picture. Everything's very uniform looking. All right, whereas microcytic hypochromic is when your MCV is lower than the reference range, so it's less than 80, and MCHC is also less than the reference range, it's less than 32. So this is telling us we have very small red cells with a very increased central pallor. So iron deficiency anemia, sideroblastic anemia, thalassemia are all, and then anemia of chronic disease, which is kind of listed in the last one here, chronic disease. These are the ones that are good examples of microcytic hypochromic. So iron deficiency, sideroblastic, thalassemia, and anemia of chronic disease. So when you look at this, you can look at the red cells here. You definitely see the enlarged central pallor. The area of white is very pronounced. That should be really immediately seen. As far as size goes, you might be like, yeah, they look different sizes, but overall, how do you know if they're smaller than they should be? And one quick way to look at this is if you're on the microscope, find yourself a lymphocyte. So this is a lymphocyte right here. Your red cell should be about the same size as that nucleus of the lymphocyte. So when I look at the red cells, are they about the same size as this nucleus? Is this one? No, not, no, no, no. You can kind of get the point here. When I look around, all these are much smaller than that lymphocyte nucleus, telling me that they are small cells, so they are microcytic. Excuse me. And then our last category would be macrocytic, so where the MCV is greater than 100, so very large red cells. The MCHC is a lot of times normal on this one. Once in a while you might see it low, but it's the MCV that's key, where it's large red cells, macrocytic. There are actually two types of macrocytic anemias. We have those that we consider the megaloblastic type, in which they're caused by either vitamin B12 deficiency or folate deficiency. And then we have what we call the non-megaloblastic that fits into here, which is liver disease. So basically there's kind of two categories underneath the macrocytic anemia category. So we got megaloblastic, which is either due to B12 deficiency or folate deficiency, and we have a whole chapter on that, so we'll get into that later. Or it could be the non-megaloblastic category, which is due to liver disease. All of these would produce a macrocytic type red cell. So when you look here, the arrows are kind of pointing to the macrocytic there. I know that the picture's kind of zoomed away, but again, look at that lymphocyte. They gave you a lymphocyte in the picture. The nucleus here, you can see there's more than just the arrow cells that are bigger than that nucleus. Most of the cells in this picture are bigger than that nucleus of that lymphocyte. So you can see it's a quick indicator to show you, yep, definitely large macrocytic red cells. Again, normal chromic, so the central pallor is just fine. It looks like normal. All right, so that's how we mainly categorize our anemias, is due to those MCV and MCHC results, our red cell indices, if you will. The other red cell indice that we haven't talked a lot about, we just briefly mentioned last week, is the RDW. So RDW is a value given to you by your analyzer. It's nothing that you have to calculate. It's given to you by your analyzer. And this is the one that will indicate if you have anisocytosis present. So anisocytosis is telling you anytime your red cells vary in size. So it could be you have a lot of smaller ones and then some bigger ones mixed in. That would be anisocytosis, where you have variation in sizes. So there are a few anemias that are well known to have a high RDW, indicating anisocytosis. So again, anytime that RDW goes high, that tells us there is anisocytosis. So iron deficiency anemia, that second one is very much well known for that. Same with the third one, which is vitamin B12 or folate deficiency. Those are known for it as well. And so when you look at this, how you would tell, again, down in the bottom right, they kind of give you a lymphocyte there. Look at the nucleus and start comparing cells. So we see a bunch of cells that are smaller than that nucleus, telling us it's microcytic, but then you see a bunch of cells that are bigger or just the same size as that nucleus, showing larger cells. So you can see it's the variation happening here. There's a mixture of cells. Now, to know what category, if it's microcytic, normocytic, or macro, you'd have to look at all the fields or more than just one field anyway, get a good range to get a feel on what the majority of cells are. But again, anisocytosis is just anytime you get mixture of other cell sizes in there. So there's a little bit of a flow chart based on those things, the absolute retic count and the MCV. So again, reticulocyte count comes more into play with just hemolytic stuff. So when you look at this chart, it says if you have a retic count that's high and you go over there, that shows all about hemolysis. And then if your retic count is normal or low, then you can look at more MCV stuff and categorize the anemias again that way. All right, so a little bit on those hemolytic anemias because we haven't discussed it much yet. Again, they're going to fit into the normocytic category, so their MCV is normal, but they will have that elevated retic count because they're trying to replace the destroyed cells. There's a lot of reasons why you might have a hemolysis occurring, and we have many chapters on hemolytic anemias coming up, so I am not going to get into this yet at this point. All right, so this, we can just kind of skip the end here. This is just extra information. Again, if you want to read through, you can. This is just talking about what might cause hemolytic processes. Again, we are going to have chapters upon chapters on that coming, so we're going to hang off on that. All right, so let's go into the next PowerPoint, which is going to be Chapter 20. It used to be Chapter 19. I'm sure you're getting sick of hearing that. But I think when I loaded it up, it was called Chapter 19, but it's truly Chapter 20 now in your new textbook. So this is our very first diving into anemias. We have 3 anemias in this chapter that we're going to really dig into and learn more on. So now that we're kind of done with the broad overview, we're going to dig more into this. By the way, what I should mention before I go too far and forget, in this chapter, in your textbook, there should be the shapes of red cells, the poikilocytes. Poikilocytes are shapes. There's mention, and they'll give you the different shapes that you can find with red cells. Those shapes will relate to different diseases. And I need you guys to start getting to know that, like, oh, this one goes with target cells, this one goes with schistocytes. I believe you have this week a study guide on that to help you really start to dig in and learn those shapes and learn diseases it goes with. So that's just kind of FYI, that's all coming out of Chapter 19 there. And when we start into this Chapter 20 and learning these, you're going to hear mention of some of them when they link to different diseases. All right. So the first group of anemias all have to do with some sort of disorder of iron and heme. So there is the 3 that we're going to learn in this chapter. So we have iron deficiency anemia, which is just like it sounds. You're deficient or low in iron, so inadequate storage of iron. You have anemia of chronic inflammation. You could also call it anemia of chronic disease, same thing. That basically relates from impaired mobilization of iron. And then the third one we're going to learn is sideroblastic anemia, in which there's some sort of red blood cell defect that's preventing the iron getting into the heme ring when they're making it. So you can see all 3 relate to iron somehow. So we will start with the iron deficiency since that is the most common anemia. So etiology, basically the cause, again, it will develop any time that you do not get enough iron in your diet, so you're not taking in enough, when you have extra need for more iron, or when you're losing iron out of your body. So if you have like a blood loss, you know, like a GI bleed over time, you will lose it. All right, so iron deficiency typically develops pretty slowly. It doesn't come on really quickly. It's something that kind of goes on through time. And remember, your iron is split into 3 compartments. You have your ferritin, which is your stored iron. You have iron that's constantly being transported attached to that transferrin protein. And then you have iron that's in your hemoglobin molecule, all inside the red cells, all around your body. There's also another type of protein called myoglobin that's found in your muscle. That actually has iron in it as well. So that's kind of where your iron is distributed at all times in your body. So when you look at this, it will go through stages on how you develop iron deficiency anemia. And this slide is important for us to take away and remember. So stage 1, everything is normal except the ferritin, the stored. Anytime that we're starting to lose iron and need more iron, we're going to go right away to our storage first. We're going to use up what's in our storage before we have anything else get depleted. So we'll deplete the storage, so you'll start to notice that the ferritin goes low. In stage 2, that's when it affects the transport iron. So we've already depleted the stored, now we're going to deplete the transported iron. So you're going to see the serum iron value goes low, but the TIBC is increased, and that is a key finding with this anemia. So TIBC stands for transport iron binding capacity. What that means is that transferrin protein all of a sudden has a lot of room on it, a lot of binding capacity for other iron to bind with because you're low. If you deplete what's being transported and you don't have any serum iron to transport, all of a sudden you have a lot of room on your transferrin protein to bind with iron. So that's why you see the increase in iron binding capacity. It has nothing on there, so it has room to bind. And then finally, the third stage is your depletion of your hemoglobin. And that's when you really see the full anemia take place. So that is kind of the evolution of iron deficiency through stages that I do ask you to know. All right, who does this affect? Epidemiologies. It's usually mostly women more than men, especially if they're menstruating, adolescent girls that are growing, pregnant nursing women where they have expanded need, you know, anything like that, but it's typically more women than men. So to diagnose it, of course, when we do the CBC, you're going to obviously see the anemia. You'll see low red count, low hemoglobin, low hematocrit. Those three are always a good sign that there's an anemia happening anytime you have low red cell, low hemoglobin, hematocrit. You will see the MCV and MCHC also be low because iron deficiency is a microcytic hypochromic anemia. So MCV and MCHC will also be low. You're going to see an increased RDW, so that'll be greater than 15% to show it's increased. That will tell you there is anisocytosis, that variation in sizes of red cells. And as far as shapes go, when you look at it under the smear, you will see some poikilocytes, some shapes. The two that are really contributed to iron deficiency are target cells and elliptocytes. Those are the two primary poikilocytes that you find in iron deficiency anemia. So now that we kind of have seen those results, the doctor might start getting an idea of, okay, this might be iron deficiency is occurring when they see these results. So to diagnose it, let's measure their iron levels. Let's see what their serum iron is, their TIBC, their transferrin saturation, and their ferritin, their stored iron. So just a reminder, iron studies do vary throughout the day, so they're kind of what we call a diurnal variation. So they will drop throughout the day. They're higher in the morning, and then they drop throughout the day. So the doctor does take that into account when they're drawn. So, all right. So typically with iron deficiency, you're going to see a low serum iron, a high TIBC, a low transferrin saturation, and a low ferritin level. Those would diagnose this as iron deficiency. So again, low serum iron, high TIBC, low transferrin saturation, because there's nothing on there to saturate it, and low ferritin. So that is your key to diagnose the iron deficiency. As far as treatment goes, figure out why they're iron deficiency. That's where the doctor does the digging. They ask questions, kind of like, what's your diet? You know, are you only on a soup and cracker diet? You know, like, what are you doing in your day-to-day life? Let's screen you to make sure you don't have a GI bleed. Do you have black kind of stools? Is there any blood in your urine? Like, they're going to just kind of dig in and figure out why are you getting iron deficient. So they're going to treat them with iron, the dietary supplement iron, and then whatever the underlying cause that might be resulting in. If they have a GI bleed, let's take care of the GI bleed. If it's a parasite, let's take care of a parasite. You know, whatever it could be causing the low iron. All right, so again, that was a representation of a microcytic hypochromic anemia. In here, I'm hoping you can see my arrow. To the left, kind of to the kitty corner left of that lymphocyte is a target cell. So it looks like a target. So that's, again, a cell that you would commonly see in iron deficiency anemia. There's a few other targets in here that I see. So those kind of go with this. They go with a few other diseases as well, but they're seen here. And then there is a nice elliptocyte down to the kind of bottom right. That oval shape there, kind of elongated oval shape, that is an elliptocyte. So those are your two more seen poikilocytes for iron deficiency. All right, let's go on to our next anemia, which is anemia of chronic inflammation, otherwise known as anemia of chronic disease. This is the most common anemia among those that are hospitalized. So the cause of this is you do have some iron. You're not totally deficient in iron like you are in iron deficiency, but your iron absorption is decreased during inflammation. So they have some sort of chronic illness, that's why it's called chronic disease, that has inflammation as part of it, and it's impacting their iron absorption, their iron availability to developing red cells in the bone marrow. So they're not totally depleted of iron, but it's definitely impacting how they're getting iron. So I don't know if all of you have been through clinical chemistry or not. If you have, it might help. But there's what we call APR, not the interest rate deal on finance, but in our world, APR stands for acute phase reactant proteins. So again, acute phase reactant proteins. Those are the proteins that when there is inflammation present, increase in numbers. So anytime there is inflammation present, we have acute phase reactant proteins that respond to that inflammation and increase in their numbers. And I've listed 3 of those proteins here that do this. And this is what causes the problem and results in an anemia for people that do have chronic inflammatory diseases. So first we have hepcidin. This protein regulates body iron levels by reducing the amount we absorb. So if you increase, all of a sudden, because you have inflammation happening with your disease and you're increasing the hepcidin levels, well, it's increasing the ability to keep reducing the amount of iron absorbed. Lactoferrin is another one. This actually will bind iron. It's a protein that's going to bind iron and take it away so transferrin can't have it. You have the iron, but transferrin's not allowed to have it to bring it to the bone marrow because it's already bound it. And then, of course, ferritin. Ferritin is our stored iron, but it's a protein. It's what stores our iron. It is actually an acute phase reactant protein, so it will also bind iron and take it away and store it extra than it should whenever there's this chronic inflammation happening. So you can see how these 3 proteins really impact the availability of this iron to the patient, which is what then results in the anemia happening. So it says, iron is present in bone marrow macrophages. It's all stored up here in these lactoferrin, ferritin, but its release to developing red cells is slowed. So we're going to see it in there. It can be seen when you stain, but it's just not available. It's bound up in these proteins and not, can't get there. So to diagnose this, through the CBC, you are going to see this starts as a normocytic normochromic anemia. It will start as a normocytic normochromic where the MCV, MCHC are normal, but that will eventually go into a microcytic hypochromic anemia state. So overall, anemia of chronic inflammation fits into 2 categories. It fits into the normocytic normochromic, and it also fits into the microcytic hypochromic category. I just tend to link it into the microcytic one, but it will kind of transfer both, it can start in the normal and then go over into the microcytic. So just an FYI, it does kind of go into 2 categories. All right, so you'll also see, of course, the signs of anemia: low red count, low hemoglobin, low hematocrit. If you did the iron studies, because you're like, well, this looks like iron deficiency, it could be, you're going to see that the serum iron is low and the TIBC is also low. And that is the key difference to separate whether you have iron deficiency or anemia of chronic inflammation. Again, in iron deficiency, because they're truly depleted of all iron, their TIBC is high because they have lots of iron binding room and no iron to put on there. In anemia of chronic inflammation, that TIBC is low. They have iron, and the iron is on the transferrin, but there's just not enough of it. There's some that are bound up by ferritin, some that are bound up by, lactoferrin, all those proteins we just discussed. But there is some also bound still on the transferrin protein. So the TIBC is low. There's binding, they have bound iron still on there. But that's kind of a difference there with the iron study. So that TIBC really separates between the 2 anemias. Now, if you were to stain the bone marrow, again, we don't always jump to bone marrow, but if you were, the key stain to any time you want to look at iron storage is Prussian blue stain. Prussian blue will stain the iron granules and kind of show us that, yep, it's there. So when we were to do that, we would see that there is iron available in the macrophages. It's just not getting over to those red cell precursors and being put into the heme rings to get out there. So There are other specialized tests. I'm not going to worry about those. They're mentioned there if you like. As far as treatment goes, you know, you can give iron to help try to kick up some of the iron they have in their body, and then overall treat the chronic inflammatory disease that they have. Try to make it, you know, as good as possible with that condition they have, so hopefully the iron plus treating the disease itself will combo effect to, you know, let up on that anemia. And then finally, our third one in this chapter is sideroblastic anemias. The principal cause of this is that there is some sort of interference with the production of their heme ring. So they're trying to make those heme groups, and, you know, inside this heme are the protoporphyrin ring, and while they're making that protoporphyrin ring, something's not going right. As a result, they cannot put the iron inside that protoporphyrin ring. You have a lot of iron in the bone marrow. There's an abundant amount, but it can't get inside there because there's some sort of bad production deal. So to diagnose this, again, this is also a microcytic hypochromic anemia. So all three in this chapter were under that microcytic hypochromic category. Again, if you were to take that Prussian blue stain to look at the iron in the bone marrow, you're going to see that there is definitely iron, definitely little blue iron granules in the mitochondria, because remember, you're making your heme ring in the mitochondria, and you've got the iron sitting in the mitochondria waiting to be put into the heme, but it's just not being put in there yet. In fact, it'll kind of look like it's circling around it, and it's called ringed sideroblast, and it is what we named the anemia after, sideroblastic anemia. And there it is. So all those little blue granules are stained with Prussian blue. That is iron. And you can see how they're circling around waiting to get in, but you can't get in because there's a interference in the production of that heme, protoporphyrin ring. So that is a key sign of sideroblastic anemia, are these ringed sideroblasts. All right. As far as types, there is actually a few different types of sideroblastic anemia. One of the types is lead poisoning. So lead, when you have lead taken into the body, it actually will interfere with that protoporphyrin process, that synthesis process. So it kind of tells you specifically where it's interfering. If you don't want to worry about where, that's okay. There's a lot of steps to making protoporphyrin ring. So it basically will kind of interfere and impact several of those steps to making that protoporphyrin ring. As a result, you're not really making the protoporphyrin ring, and thus you can't put the iron inside of it. That's the principle behind it for lead poisoning. Now, we all are aware that lead poisoning causes huge effects on children. It leads to impaired mental development. There's that whole lead water kind of deal going on in Flint, Michigan, where that's really made national news and gotten attention. And it is. It really has a huge impact on the central nervous system, leading to that impaired mental development. So those are some classic findings for lead poisoning cases. You also will see abdominal cramping, vomiting, seizures possible as well. So to diagnose, again, it's a microcytic hypochromic. This one I want you to leave just as microcytic hypochromic. You are going to find what we call basophilic stippling. That is an inclusion. You'll see that in chapter 19 in your book, and under the inclusions. Basophilic stippling is basically red cells that look like they have like polka dots. And those polka dots, those stippling, are actually made up of ribosomes. So you have these little ribosomes that are polka dotting the red cell. And when you look at it under a normal manual differential, you'll see that. And basophilic stippling is a really classic finding in lead poisoning. To treat it, you want to get the lead out of the body. And then once you get the lead out of the body, hopefully everything will kind of resume back to normal, especially if you caught it in time without prolonged exposure and all that. But you can take actually EDTA salts. You know, we learned about EDTA in our purple top tubes, but you can actually take EDTA salts, and that will bind the lead and draw it out and excrete it into the urine to get rid of it. The other type of sideroblastic anemias are porphyrias. So porphyrias are, there's a whole chapter in chemistry on these, and because there's all these steps in place to make a protoporphyrin ring, any time that you're missing any one of those enzymes in that pathway can result in a porphyria. So there are actually many different kinds of porphyrias out there, because you can be missing a various enzymes. You can be missing an enzyme at the beginning or an enzyme in the middle. So anytime there's a deficiency in enzyme, it will impact it, and you're not going to make your protoporphyrin ring for your heme. So that's kind of it on sideroblastic anemia. So we kind of went through our three main anemias in this chapter. I do need you to remember, just the cause behind each one, the lab findings, things like that we kind of went through on each one to help separate between them. So let's flip over to the other side. Since we're all on the whole topic of iron, we're going to discuss a disease that's actually iron overload, so the opposite of anemia. And that is hemochromatosis. It's bolded there at the bottom. So this can be an acquired condition or hereditary, but it's excessive amounts of iron in your body. So when you have all this iron in your body, you have to store it, and you can only store it in the liver before the liver gets full, and then you also have to store it in other cells. So eventually you're finding iron stored not only in the liver, but the heart, the pancreas, the skin, and all these cells throughout the body just trying to put this iron away somewhere. That will eventually cause damage to all those organs. Once that becomes too stored, you're going to damage that liver and heart and so on where you've been storing it. So that is the downside to having too much iron. It does damage those cells that it is being stored in. So hemochromatosis, this is kind of a view of the damage. So in your skin, when you store it in your skin cells, it actually kind of makes you have like a nice golden tan. If you think about it this way, people with anemia, low blood, pale. People with too much iron, tan. But they will damage the skin cells. Liver, when you damage the liver cells, it can result in cirrhosis, that kind of hardening of the liver. Cancer, it could be hepatocellular cancer could happen. Pancreas, you destroy those pancreatic cells. It might destroy those cells that make insulin. Then you could develop diabetes. In the heart, damaging the heart could lead to congestive heart failure. So you get the idea. Anytime you damage an organ, things happen to that organ then, and that has an impact on the patient. So most of the time this occurs more in men than women. So it's typically men between 40 to 60 years old. So to diagnose it, you are going to see high levels of hemoglobin and hematocrit. So kind of the opposite of what we see with anemia. You're going to see increased hemoglobin hematocrit. When you would do, if you did iron studies, you would show the iron studies hugely increased as well. So like in this case, they're saying transferrin saturation greater than 60%, which is extremely high. Transferrin saturation should only be about 15 to 30. So above 60 is insane. You can see signs of organ damage. If they have their liver damaged, you'll see high liver enzymes. Things like that. So all the iron studies are basically the key to diagnosing this, and you're going to all see them elevated to show it's iron overload. So to treat it, we need to drain them of some of this iron. So that's where we do therapeutic phlebotomies. So you actually have them come in on a very scheduled basis. The doctor sets up the schedule, and they come in, and you basically take out a unit of blood for them. Kind of like when you go and donate blood and they take a unit. We're doing the same thing, only this time it's in the hospital setting. So you take out a unit of blood, you're just throwing it away, and that way, by them coming in on that schedule and getting a unit of blood taken out every time, you're lessening how much is in them. And you're monitoring their hemoglobin, hematocrit to make sure that, it's going down the way it should be going down. You could use some iron-binding drugs as well for excretion. That's another option. The key is just to get that iron out. All right, so that is it for this week. As always, if you guys have any questions on anything, please don't hesitate to reach out to me. I hope you guys have a fabulous week. Thank you.